to today's Lunch and Learn webinar, Improving Oropharyngeal and Oral Cavity Cancer Incidence through Interprofessional Collaborative Practice. I am Shannon Robertson, Director of Clinical Quality with Louisiana Primary Care Association. Our presenters for today are Dr. Douglas Cross, dentist who is currently the Dental Director for Excel Incorporation. He has 35 years of experience as a dentist and currently serves as the Vice Chairman of the Louisiana Primary Care Association's Clinicians Branch. We also have Dr. Betty Lowe, who's an Associate Professor of Clinical Medicine and Pediatrics at LSU Health Systems in New Orleans. She collaborates with the National AHEC organization and the CDC to educate healthcare professionals in HPV immunizations. And lastly, we have Dr. Tina Gonaldo, who is the Director for the Center for Interprofessional Education and Collaborative Practice at LSU New Orleans. She develops, implements, and evaluates new models for team-based education in academic settings and team-based collaboration in clinical settings. During this presentation, each speaker will provide dental providers with an overview on a collaborative team-based approach to preventing oropharyngeal and oral cavity cancer incidents. In addition, information on HPV immunizations will be provided to improve practitioner knowledge on the vaccine. Just a housekeeping item, in order to stay within our time frame, we will hold questions until the end of the presentation. All participants will be in listen-only mode. Please type in your question throughout the broadcast in the question box located on the webinar screen. If we run out of time, you can email your question and we will follow up with you after the webinar. Our contact information will be displayed at the end. Thank you for participating in this presentation. Dr. Gonaldo, you may begin.
Can you hear me, Shannon?
Yes, ma'am.
Okay, great. Hi, everyone, and thank you for spending your lunchtime with us. And so today we're focusing on, the prevention of oropharyngeal cancer through a team-based approach, specifically looking at HPV today. So as you know, the objective today, like Shannon said, was to improve your knowledge, your attitude, and your interprofessional practices of oral health care, and specifically preventative care as related to the HPV vaccination. And we're going to talk about the word interprofessional as we move along. And so I always like to show this one slide, which really gives us an overview of why do we start talking about team-based care. And specifically what this slide shows you is that you have the different countries throughout the world, and the United States, if you see it on the last column, really presents itself as sometimes in the middle to last in terms of ranking, but then also if you look at the very bottom row where it says health expenditures per capita, we're the most expensive. And so by far that's not anything new to anyone, but this is one of the reasons team-based care can be effective. How can we help improve the quality of care, the access to care, the efficiency to care, while actually saving healthcare dollars? And so when we think about that, we might think about the term population health, which seems to be more of a trending term these days. And if we're specifically looking at vaccinations, we know vaccinations have helped reduce cases of disease, cases of death, have helped to increase life expectancy over the past 25, over the past 50 years. And why that is so important to start thinking about population health sometimes as a broader view on how we see our patients and clients versus when we treat them individually is because that first quote, I think it says it all, only 5 of the 30 plus years gained in US life expectancy over the past century were directly due to medical care. And so there is a better way, and how can we participate in that better way? And so if you look at the factors too that affect health, this is a big pyramid, and it says what has the largest impact on improving the health of the communities that we serve or the populations that we serve. And you can see at the very bottom of the triangle, the largest impact is socioeconomic factors. And then if you look towards the middle, the long-lasting protective interventions, which such as immunizations, which we will talk about just in a little bit, and the education that we provide, all these clinical interventions and education that we provide at the top of the triangle actually have the smallest impact on health. So how can we become more efficient health providers in this day and age? And so when you look at the big picture, and for those of you who are on the webinar who have not heard of the IHI or the Institute for Healthcare Improvement, Triple AIM, I encourage you to look it up. And so that's www.ihi.org. And basically, the triple aim sets a goal for us here in the United States. We want to improve the health of populations, we want to increase the experience of care, and we want to decrease the per capita cost. And the big purple triangle, the big purple arrow just says, how might we do this? And so interprofessional collaboration or team-based care, your evidence-based practices that you learn about, electronic health records, there's so many various ways to which we can achieve the triple aim as we move forward. And so when you're talking about interprofessional collaboration, there is a definition. There's an international definition that we embrace, which is when multiple healthcare workers from different professional backgrounds work together with the patients that we see, with the families that are there, with those people who are actual caregivers and communities to deliver the highest quality of care. And so the team-based approach to healthcare is really, what can we do working together to improve health outcomes? And so applicable to dentistry, I just want to let you know, starting on the education side a few years ago, it's mandated now that if an individual comes into a dental school, whether you're talking about a dentist or a dental hygienist, that they are required to have some type of team-based training. And that's what this book is about. It was established, this report, back in 2011. It was just updated in July of 2016. But as you can see, the arrow points to ADIA. ADIA is very much a supporter of team-based care, collaborative-based practice. So as population health, when we consider oral cavity cancer or oropharyngeal cancers, we know what the modifiable risk factors are. We know it's tobacco use, we know it's alcohol use, we know it's the HPV infection, and then poor nutrition and diet. And so what I ask of you today is to think about how can you as an oral health provider address these modifiable risk factors. And so when you look at these two graphs, you see that over time, cigarette smoking in the United States for adults has decreased, right? Over time, you can see that as the green line goes across, the horizontal green line. And then if you look at the graph to the right, you'll actually see the incidence of oral cavity and pharyngeal cancers. And you can see how it started high, it moved down low towards 2005, 2010. But if you actually go and you click on that slide, you'll actually see that there's a slight uptick. And why are we seeing a slight uptick in oropharyngeal cancers if smoking is going down or trending down? And maybe they're thinking that's from the HPV, so the human papillovirus. And so one of the things that I think is really important for all of oral health providers to understand and know is that if you start to ask your patients about, are they immunized? Are they current? Are they up to date? What are they thinking about their immunizations? And specifically HPV, if we all do that as oral health care providers, as physicians, as nurses, as physical therapists, that actually contributes to this consistent public health message, which then we're all saying the same thing to the patients and the families that we see about how can we improve population health. And so along with that, we do have supporters. And so you have the Department of Health and Human Services. They developed the Oral Health Strategic Framework, and their #1 goal actually says, how can we as oral health providers work together to integrate oral health and primary care? Maybe asking about, or I shouldn't say maybe, I should say asking your patients about, are they up to date with immunizations, is a collaborative approach to help integrating oral health and primary care. And then if you look at the ADA and their position statement on the actual virus and cancers, you'll actually see their support of a collaborative approach. And then you also have the goals of Healthy People 2020. And so just to let you know, a few weeks ago at the LSU School of Dentistry Alumni Day, we did a similar presentation, but it was not focused on HPV. It was just giving a global overview of population health. We asked the question to the participants, how many of you think you're an integral healthcare team member for the prevention of oropharyngeal cancer? And obviously you can see a great percentage. 86% of those individuals thought they either strongly agreed or they agreed with, yes, I'm in here to help prevent this type of cancer. Then we subsequently asked, do you ask your patients about the HPV vaccination? 54% strongly agreed or agreed. And we asked these same questions as it related to the 3 major modifiable risk factors, so tobacco use and alcohol use. And you can see straight across the board, asking your patients about the vaccination, providing HPV education, providing a referral, and then follow up to the HPV, the percentages to where oral health providers agreed or strongly agreed, which was lower as compared to asking the same questions for tobacco and alcohol. And I will tell you, this is something we see in the literature, I've seen in the literature. Years ago, when they started coming out and saying, should oral health providers talk to their patients about smoking cessation, or should they talk to their patients about alcohol use disorder or the abuse of alcohol, the percentages were lower. So as we're seeing, like we are now with the HPV vaccination. And so I think it's just time to where we can get oral health care providers to think, yes, I can be a part of this population health movement to improve immunizations, specifically HPV. And if you do that, and if you look further into the literature, you'll actually have 2 evidence-based practices that kind of let us know what do we need to do in order to truly help our patients, educate our patients, and then follow through. And you can see whether you want to use the 5A approach or you want to use the 5R approach. It's talking to the individual, the patient, the family, in this case, sometimes the parents, you know, have they had the immunization for HPV? Do they have any hesitation? Why or why not? Why is it relevant for your child to have the vaccination? And then what's really important, because more than likely they're not going to be getting the actual immunization within your dental office, is that what is the follow-up that you're doing to ensure that these individuals are getting the vaccination that they need? And so with that being said, I'm going to turn it over to Dr. Betty Lowe for her presentation. And this last slide, while we're switching over, I'll just let you see that you can see there's lots of resources here, and I know it's specific to the greater New Orleans area, but there is an immunization bus schedule, and we'll get you this slide deck after so you can ask your patients if they haven't had the immunization, where can they go and get that immunization for free. The schedule for the bus is up on that website. There's CDC posters in English and in Spanish. Develop an office process, and for any of those who need our help, and I can help brainstorm with you, how can you develop an office process that is evidence-based that can help improve vaccination rates? And then also access to viewing links, which is our Louisiana immunization web-based system. Shannon, if she can hear me.
Shannon? Shannon?
Yes.
Can you hear me?
Yes, I can hear you, and we can see your slides.
Okay, great. Thank you.
Mhm.
So good morning. Thank you, Tina. So it is a delight for me to present my version of the HPV vaccination in this collaborative interprofessional relationship that we're trying to develop between primary care as well as dental providers. And I find it very exciting, and for many reasons, because as an internist and a pediatrician, primary prevention is absolutely at the foremost of one of our priorities. To prevent disease before it actually takes place is crucial. And if we can do this at an early age, we can actually prevent a lot of morbidity and mortality associated with HPV. So as Tina had mentioned with the objectives, we are going to also talk about the importance of vaccinating with the HPV vaccine for cancer prevention, as well as the rationale for why we vaccinate our youth at the ages of 11 or 12. We're going to also list the recommendations for administering the HPV vaccine to both boys and girls, and we're going to provide some useful and compelling information about HPV to our parents that will help them make a decision to vaccinate their children, and then also provide resources that are relevant to our current immunization practice. So I think it's important to mention about a little bit about the pathophys of HPV. We know there's over 120 types of HPV. 80 of the types are actually cutaneous. So those are not oncogenic at all. Those are the common hand and foot warts. But there are 40 types that definitely affect the mucosa, whether it's the mouth, the throat, or the genitalia. And we do know that the high-risk HPV strains, two of them, 16 and 18, probably cause about 70% of the cancers that we are facing today. There are two strains that are lowest risk, 6 and 11, which are causing 90% of what we call the non-oncogenic problems, the genital warts, the laryngeal papillomas, as well as low-grade cervical disease that does not go on to progress to cancer, but still causes problems for women. So the highest risk strains are causing a number of our cancers for males and females that are certainly of concern: cervical, anogenital, oropharyngeal, as well as high-grade cervical disease, which definitely can progress to cancer. So let's just take a look at some basic photos. So the common warts, I think most of us are familiar with, that again, cosmetically not pleasing to the eye, but definitely not cancer-causing. And some of the oral warts that many of the providers may have already seen. And then genital warts, which again do not cause cancer, but can be psychologically debilitating for some of our children and young adults, and even adults facing these. Oropharyngeal lesions, again, that may be precancerous or cancerous. Laryngeal lesions that we can see via vertical transmission from mother to child. So those are just pictorial depictions of what HPV can do. And a picture is always worth 1,000 words, in my opinion. So if we look at the incidence of HPV, it is the #1 sexually transmitted disease. It's not syphilis, it's not chlamydia, it's not gonorrhea, it is HPV, human papillomavirus. And approximately 79 million Americans are currently infected at this point in time. And there are 14 million new infections per year in the United States, and it's most common in people in the teens and in early 20s. 50% of all the new cases are occurring in the highest risk group, which are the 15 to 24-year-old kids, which actually are probably the most promiscuous group, and the ones that we actually screen for chlamydia and gonorrhea, primarily in females. So most people, unfortunately, will never know that they have been infected. So if we take a look at this, and honestly, I don't want you to get too bogged down in the details. The most important thing is to notice is in the darkest blue part of the graph, that is the incidence of the percentage of HPV causing cancer for men and women, predominantly affected by strain 16 and 18, which I already told you causes about 70% of cancer-related HPV cancers. And you can see that cervical cancer stands out for women, or oropharyngeal cancer stands out for men. But then you've got the vulvovaginal, anal rectal, and the penile cancers in between. So when you look at the effect of HPV on our population, so 91% of cervical cancers, 91% of anal cancers and rectal cancers are caused by HPV. But oropharyngeal, 70% are caused by HPV. And you can look at the total, 31,500 people per year are diagnosed with some HPV-related cancers. And oropharyngeal cancer has actually overtaken cervical cancer numbers, which certainly is of concern. So we've already discussed some of the risk factors related to HPV positive and negative oropharyngeal cancer. But if you notice with HPV positive oropharyngeal cancers, it's happening in younger persons, males and females, with exposure to sexual activity, both oral and vaginal. And these are 20 and 30-year-old adults that are being affected versus the HPV negative, which are usually the older adults that have consumed alcohol or have been exposed to nicotine. So this slide I am putting up because you can see that this peak that we're seeing in blue is the oropharyngeal cancer. So we start seeing an increase in the 20s, peaking at 60s. But you can see this is a marked increase from prior. I mean, I think this is one of the highest, the fastest growing cancers that we are now seeing amongst our young males, especially white males, which is certainly concerning. And if you look at the survival rates for HPV positive and negative tonsil cancer, it's actually better with HPV positive patients, but that shouldn't be reassuring because cancer is cancer. And if we look at Sweden's data, this is 46 years worth of data. So we see that they are actually seeing, and you can see the black line with the HPV positive cases of tonsillar squamous cell cancer, that they have seen a marked increase just over the past few decades with HPV positive tonsillar squamous cell cancers. So I'm going to focus a little bit on cervical cancer because probably most of our data is regarding cervical cancer. And why is that so? Well, cervical cancer is the most common HPV-associated cancer amongst women, but it's also the third leading cancer in the world. And it's the second leading cause of cancer-related deaths in the world. As you can see, there's over 500 million new cases, 500,000 new cases in the world, and then 266,000 deaths worldwide. Luckily, in the United States, we see only 12,000 new cases, but we're experiencing 4,000 deaths and unneeded deaths, hopefully in the future. And we can do better because one cancer death is one too many. So if you notice that 50% of our cervical cancers are not happening in older women, they're less than 50 years of age. And 25% of those cases are occurring in women who are only 25 to 39 years of age. So this is a cancer that afflicts young women and older women. It does not spare anyone. So if you think of the implications, you may say, oh, it's only 12,000 new cases. But look at the implications of cervical precancer. We're now affecting 1.4 million women with cases of low-grade cervical dysplasia, but 330,000 cases of high-grade, which could go on to definitely progress to cervical cancer if left untreated. So HPV-associated cancer rates, we're talking that about cancer that spares nobody. So Blacks and Hispanic, people are afflicted the most, but as you can tell, there is absolutely no race and no ethnicity that is spared. So again, some photos to demonstrate what we see when we're doing a female exam. And again, these are genital warts, and unfortunately, very, scary for the patient to have to experience this. So some of these warts can look just like cancer, and then we are forced to biopsy, and they go on to do some other invasive procedures that hopefully we won't have to be doing in the future. So with HPV progression, you can just look at the cellular atypia on the top, and then in the middle, the actual changes that we see grossly on a cervix. And on the right side of the picture, that is cervical cancer. Certainly something we want to avoid, because certainly if you have to have the cervix removed and possibly the uterus, we're talking about infertility for this female. So this is an exciting portion of the talk. That's a little pathophys, is that now we have a vaccine that actually can prevent cancer. This is not the first vaccine, though. The hepatitis B vaccine is actually a cancer-preventing vaccine as well. But hepatitis B became an issue because of vertical transmission, primarily from mother to child, and also for patients who are afflicted because it is a sexually transmitted disease later on as adults. However, HPV is going to hopefully prevent our children and grandchildren from developing a disease that is absolutely preventable. So when we look at the HPV vaccine, it is not a live vaccine. So that's really important to remember, because it can be given to patients that are immunocompromised because it's not a live vaccine. It is made of proteins that form virus-like particles. And the wonderful thing about this is that those persons who get this vaccine actually have higher levels of neutralizing antibodies than if you were naturally infected with the disease itself. So this is just a real quick slide that basically describes our evolution of the HPV vaccine in 2006, which was the Merck quadrivalent Gardasil, but it's phased out in 2016, and we no longer have that. And that covered the highest risk strains, 16 and 18, as well as 6 and 11, which causes 90% of genital warts. And then we had the bivalent vaccine, which was only for females, covering 16 and 18. And now in 2014, which is really exciting, we're actually covering 9 strains, but we're also covering 80% of the oncogenic strains, which is truly exciting. So this is just another representation. So in the 9-valent vaccine, we're actually, in addition to covering 6, 11, 16, 18, we're now covering 31, 33, 45, 52, 58, which provided an additional 15% coverage for HPV-associated cancers. So that brings us up to a total of 80% of cancer-causing strains are being covered in this exciting vaccine. So originally, it was a 3-dose vaccination series, but in October of 2016, the FDA approved a 2-dose Gardasil vaccine, which is really exciting because of compliance issues with our children and getting their vaccinations. So the vaccination series can start as early as 9, but the preference is 11 to 12 years of age, and 2 vaccines should be given, and the age preference is 9 to 14 years of age, and the second dose must be given 6 to 12 months after. Again, the CDC emphasizes the importance of routine vaccination at 11 or 12 years of age to prevent cancer. And the reason 11 and 12 came into play because most of the immunogenicity studies were done at this age. And there's actually a more robust antibody response when this vaccine is given at a younger age as compared to 15, 16, 17, and even into the 20s. In addition, we also give 2 other vaccines at this exact same time, Tdap and Menactra. So basically, it's 3 vaccines at one time, which would make it easier for the child to get the 3 shots and then just have to come back within 6 to 12 months for the second vaccination. So the dosing schedule is relatively easy. So for the 2-dose vaccine, so much easier than 3. Again, we're administering it anytime between 9 and 14. The preference is 11 to 12 years of age. And again, the second dose is given to 6 to 12 months later. The minimum interval between the first and second dose is 5 months. So if you give it at the 5-month mark, it's absolutely okay. If you give it before 5 months, then you will have to repeat. You'll have to give an additional dose. So then now the person is going to have to actually comply with the 3 doses of the HPV vaccine. So it's critical to administer this vaccine before the 15th birthday. That's really important. Now, the caveat is that the age of the receipt of the first vaccine dictates how many doses. So if I give that vaccine anytime before the 15th birthday, even if I'm 21, I only get the second dose. I don't have to give an additional dose just because I did not give it within 6 to 12 months. So if you start this vaccine at the age of 15 or older, then you fall into the 3 doses of the vaccine, which was the original vaccination series. And we think of this just like the hepatitis B vaccine. You're going to give it now, and then you wait 1 to 2 months later for the second vaccine, and then you have to give it the 3rd dose, usually 6 months after the first vaccination. So again, it's 0, 1, and 6 is typically what we remember the 3 doses to be given. So if the patient did not follow through and get the vaccine before the age of 15, which is recommended, then you can actually catch up and still give the vaccine for females through the age of 26 and for males through the age of 21. Although off-label use, there are patients who have been getting the vaccine at 27 years of age, which is approved in other countries, just not our country. And again, that may not be paid for by the insurance, but there is an off-label use if you give it beyond 26 years of age. For males 22 through 26 years of age, the recommendation is yes, you can actually give this vaccine through 26 if they are gay, bisexual, men having sex with other men, transgender, and actually patients with immunocompromising conditions, including HIV. So the special populations that are included in the immunocompromised conditions are those that actually affect cell-mediated immunity or humoral immunity. And the list would be, in addition to HIV, the T and B lymphocyte deficiencies, malignancies, transplant, autoimmune patients, patients on immunosuppressive therapy. And that population, because of the concern that immunogenicity might not be adequate, those patients should also get the 3 doses of the vaccine. For patients who are sexually abused or assaulted, the recommendation is to start as early as possible. So 9 years of age is absolutely the earliest you can prescribe this vaccine. So there are diseases that many of our patients have that do not require the 3-dose series. So they can still fall in the 2 doses as long as it was given before the age of 15. And the list is long, but these are the typical patients we see on a daily basis, but they can still get the 2 doses of the vaccination. So again, immunogenicity of our 2-dose series has been comparable, even more superior to the 3-dose regimen. And even after 3 doses of the 9-valent HPV, 98% of the vaccinees developed antibodies to all of the 9 serotypes of HPV covered in the vaccine, which means that the 2 doses has been comparable, and again, over 98% of vaccinees developed an appropriate antibody response. So not only is the 2-dose series efficacious, it's also more cost-effective, and hopefully will improve compliance rates primarily in the United States. Now, Europe was actually doing the 2-dose series back in April of 2016. We had a lag time of 6 months before we actually had the 2 doses FDA approved. But we probably observed and did our own studies, watched what happened in Europe before we actually made the approval in the United States, which is probably the right thing to do. So very important is everyone's going to wonder, well, you know, how long is this vaccination going to last? So at this point, it's at least 8 to 10 years, maybe even longer, and there's no evidence of waning immunity at this point, but there are studies still in progress. So then the question became, well, if there's 2 doses are just as effective as 3, how about just a single dose? Because our single dose vaccination rates are not that bad in the United States, but they looked at almost 12,000 females ages 9 to 26 years of age, and this is patients who have received either 1 dose, 2 doses, or 3 doses. And the results are pretty stunning and astonishing. So group 1, and this is the group that received, this is the smallest group, and they only received 1 dose. They actually had a higher incidence of precancerous lesions as well as cancerous lesions. The groups 2 and 3, which almost totaled 10,000 patients, there was no significant difference in the pathology found, and there definitely was not a higher incidence of precancerous or cancerous lesions. So that was kind of the impetus to support that the 2-dose vaccine is definitely comparable to the 3-dose, and definitely the single dose is not going to be adequate. So again, CDC recommends, as well as the Advisory Committee on Immunization Practices, which primary care physicians follow their recommendations, definitely recommend vaccination starting at 9, but the preferred age is 11 or 12 years of age. And again, to capture the 3 vaccinations that are given at that age group. So again, some pictures that remind us why it's so important to vaccinate. And in the left-hand corner, so we actually, the United States and actually the entire world, when smallpox came on the scene, it was definitely a collaborative effort internationally to vaccinate as many people throughout the world. Smallpox has been eradicated in the Western world, and why is that? We don't see smallpox because of vaccines. We don't see Haemophilus influenza causing meningitis and cellulitis and pneumonia because Haemophilus influenza is included in the childhood vaccines at 2 months, 4 months, 6 months, and 12 to 18 months. We're actually starting to eradicate even pneumococcal disease in our children because why? Prevnar is at 2 months, 4 months, 6 months, and 12 to 18 months. So we're eradicating bacterial disease left and right because of vaccinations. So I always say pain now, gain, and a lot of gain later. So my mom, no vaccines at her time, but my daughter has had all 3 vaccinations. So when we talk about risk and benefit, because that is really important, risk and benefit of any medication we prescribe, a vaccination we're considering, we always have to consider the risks and benefits. And my son has also been vaccinated, he's 21. If you look at safety, you can tell that the FDA and the CDC have collaborated together, and there is extensive clinical vaccination safety assessments being done. There's an active database for surveillance of adverse events. This is really important because it's important for parents to know that the vaccine that we are recommending is safe. So there's exhaustive data being, constantly followed up with any adverse events. And if we look at the vaccine safety, we've already administered 90 million doses in the United States alone since 2006. There's 300 million people in this country, so that's a good chunk of people, right? So 90 million doses, and extensive safety testing has been done in clinical trials before the US FDA could even license the vaccines. And you can see that the number of patients that were studied was not a small amount before the vaccine was actually rolled out and approved. If you're concerned about side effects, certainly like with all vaccinations, pain, redness, and swelling in the arm where the shot was given, but that's why we always recommend the non-dominant arm, because it is an intramuscular vaccination, and then mild fever and potentially headaches. There have been reports about fainting spells, but that's not unique to HPV vaccine. So if you read about syncope in any vaccinated patients, it's usually adolescents, unfortunately. They have the highest incidence, but there's been no deaths associated with HPV. So the recommendation is if you do have someone that is feeling lightheaded, dizzy, and who do have a brief fainting spell, then we're going to lie them down supine and for about 15 minutes and observe, and certainly make sure that their vital signs are stable. So contraindications to the vaccine, obviously previous allergic reaction to a Gardasil vaccine, whether it was the 2-valent or the 4-valent, or even the 9-valent, immediate hypersensitivity to yeast, serious acute illness, and pregnancy. Although if a patient is pregnant, finds out that they are, then there's been absolutely no adverse effects, but it's certainly not recommended. It hasn't been studied in pregnant women. So we do feel the vaccination is very safe. Again, it's got a very good safety profile. There's been no evidence of death, no permanent neurological conditions, no clots, i.e. thromboembolism, venous thromboembolism in any of the patients at this point. So practitioners can definitely feel safe in recommending this vaccine. So one of the really important aspects of the HPV vaccine is looking at outcomes. First, we want evidence to support what we are doing. So evidence-based medicine is critical for practitioners. So we have a lot of evidence, and I'll even produce more evidence, but we also want to look at population impact. How is this vaccine really translating into cancer prevention? Or does it just sound good and this is what we think is happening? No, we actually want to see some data. So we've already got some early outcome studies in some high-income countries, including the United States. So the early outcomes happens in just within a few years. So we're looking at the prevalence of HPV. Are we seeing an uptick or downtick? And then the prevalence of genital warts. The mid outcome happens years to decades. So it may take, a few more years to prove that we're seeing a decrease in our precancerous lesions. And then the late outcomes is going to take some decades to prove that there's definitely a decrease in HPV-associated cancers. So if we look at our coverage right now, amongst high-income countries, Australia, which actually rolled out the vaccine in 2007, and they give this vaccine for free to 12 to 13 years of age, up to 26 years of age. So their vaccination rates, 71%, very, very good, and United Kingdom is right behind them, and then we're kind of probably at the lower end of what our hope would be. So Actually, 33% is probably better now, but 33% is very, very poor. If we look at Australia's data, just take a look at the dotted line in the center, and you can see that in 2007, this is when the vaccination was rolled out. And then you can see to the right side of the dotted line that we are actually seeing a decrease in the prevalence of genital warts amongst our kids less than 21 years of age, but you also see in the red dotted line that there's actually a potential impact amongst the older adults, 21 to 30 years of age, who probably never even received the vaccine. And that's exciting. We're vaccinating younger children, but we're actually potentially seeing a positive effect on adults that may have never been vaccinated with a vaccine. Again, some reminders of why we do this. If we look at countries that have over 50% coverage with the HPV vaccine amongst their 13 and 19 years of kids, we actually are seeing a decrease in prevalence up to 70% in the oncogenic strains of 16 and 18. But we're also seeing a decrease in the anogenital warts by 61%. And again, we feel like there's some herd effect here. So the more people that are vaccinated, the more benefit amongst the rest of the population, even if they were not vaccinated, which is exciting. So in March 2016, and published in Pediatrics, Markovitz actually, within 6 years of the vaccine being introduced in the United States in 2006, we actually have reported a 64% decrease in the 4 strains of the quadrivalent HPV in the 14 to 19 years of age. And we actually also saw a decrease in 20 to 24-year-old adults. And this was the first finding that demonstrated that we are actually seeing an impact of this vaccine that we give to children amongst females in their 20s. If we look at this prevalence, this is the exact, slide that's demonstrating what I just mentioned about the 64% decline in the 14 to 19 years of age and a 34% decline in 20 to 24 years of age. But we did not actually see an impact in adults 25 and older. So this just came out hot on the press, printed in the Journal of Infectious Diseases, Markowitz again et al., looking at the prevalence again of HPV amongst female. And now we're talking 8 years later. So what are we seeing 8 years after the introduction of the vaccine? We're seeing even better results. We're seeing a decrease in 89% of the quadrivalent strains in the sexually active women 14 to 24 years of age. And actually, we're actually seeing some herd protection, so 34% decrease amongst unvaccinated women. So we're now seeing the benefit that the more people that are getting vaccinated, we're also protecting those who have not been vaccinated. So 71% decrease in 14 to 19 years of age, 61% decrease in 20 to 24 years of age, and an overall vaccine effectiveness of 83%. Pretty darn good. Nice evidence-based medicine to support what we're doing. So I think we're still having issues among the primary care physicians potentially about how we are going to frame this conversation. So for any of us to really prescribe a medication or prescribe a vaccine, we really have to believe in that medication and vaccination. There's no doubt. But again, if we take a look at our vaccination rates, we do really well with the Tdap, which has the whooping cough vaccine and the tetanus in that vaccine. We really do well with the Menactra, which is the meningococcal vaccine. But if you take a look, then there's a steep fall off with our HPV practices. So we don't do as well with the HPV vaccines. The first one, not so bad, about 60% for females getting 1 dose. About males, it's now 50%, much better than the 30s. But when we talk about the 3 doses of vaccine, we're talking maybe 40% for females and 25% for males. So we have a steep fall off. The children were not completing their vaccination series. So the CDC actually, again, is following vaccination practices, and their national immunization survey amongst the teens demonstrated in 2016 that 65% of our 13 to 17-year-old females did get at least 1 dose. The males, 56% received 1 dose. So overall, about 60% of males and females received 1 dose between the ages of 13 to 17 years of age, but 43% have completed their 3 doses. So 43% pales in comparison to Australia with a 71% vaccination rate. Now, why is this happening? Can we prevent this? Because we don't want our children to not be vaccinated. Well, if we actually took advantage of all the opportunities that children have when they walk into our office, whether it's an acute sick visit or a well visit, we could actually achieve 91% vaccination rates compared to our 47%, 43% rates. We could achieve that number. It's possible. So the Healthy People 2020 objective that Tina had mentioned, the goal is to vaccinate 80% of our females and males aged 13 to 15 years of age against HPV. So they want 80% of the girls by 15, 80% of the boys by 15 years of age to be vaccinated. So, we know, again, HPV causes almost all cases of cervical cancer and anal cancer. Is it possible? Can we do it? Well, look at our Tdap and our Menactor rates. Not bad. We give these immunizations at the exact same time. So why can we not achieve those rates? We are going to achieve those rates. It's possible. Remember, herd immunity is key. We need at least 70% of our girls vaccinated. If we don't have 70% of the girls vaccinated, we have to continue to vaccinate the boys. So we're vaccinating boys and girls in our country, but primarily because we don't have the adequate vaccination rates for our girls. So herd immunity is a very important concept because by immunizing a critical mass of the populace, we can actually protect an entire community, and that's through high immunization rates. So vaccination protects more than just the vaccinated person. But when we look at the value that parents are placing on vaccines, sometimes primary care doctors may minimize, like, we don't really think that the parents care if their children get vaccinated with HPV. It's not that important. Well, when we look at the value that the parents place on HPV, it's the same importance that they place on meningitis, hepatitis, pertussis, influenza, and other adolescent vaccines. When we look to see how clinicians estimate the importance that parents place on the HPV vaccine, we actually underestimated the value that the parents are placing on the HPV vaccine. And actually just in adolescent vaccines and even influenza vaccine. So the clinicians are underestimating the importance of the vaccine, although the parents rate it very highly, and they feel it is very important. So when they ask practitioners, what factors do you think are contributing to the underutilization? Well, this is the clinician perception. Well, the parents don't really think their child is at risk for acquiring sexually transmitted disease, or the parents are having concern about side effects, or parents are concerned that the vaccine is promoting sexual activity, or the parents don't believe that, if their child is not vaccinated, it doesn't really hurt anyone else. So the perceived and real concern of parents really does influence how the clinician recommends and administers HPV vaccine. That was the clinician's perception. The reasons why parents don't initiate, a huge reason is because it wasn't recommended in the first place by their pediatrician, their internist, their family practitioner, etc. That's a concern, that the clinicians aren't even recommending this vaccine. So again, how do we increase the rates of vaccinations? Well, we as physicians, we really do need to give an effective recommendation. And how are we going to do that, though? We know that parents trust their physicians. And so they've already looked at moms and they put them in focus groups and they said, if my doctor told me I should get the vaccine for my child, I trust my doctor and I'm going to do what my doctor tells me to do. Of course, this should be an open dialogue. It shouldn't be, you need to have this and this is the end all be all. But parents really respect what the physicians are going to recommend. They ask you for that recommendation. So how do we give effective recommendations? we're going to say, give that vaccination the same way you give the other vaccinations on the exact same day. So again, we're talking about at the 11, 12-year-old visit, we have Tdap, which is the pertussis vaccine, along with the meningitis vaccine, and the HPV vaccine is recommended on the immunization schedule as well. So 3 of those vaccines are given boom, boom, boom. And you're going to give it the exact same day. You're not going to split them up. We have to remember that we give infants, 2-month-olds, 3 vaccines that cover like 8 bacterial strains. And we're giving that at 2 months and 4 months and 6 months and 12 months. And we're reluctant to give 3 vaccinations to our adolescents. That does not make sense. There's absolutely no reason to split up the 3 doses. So you would say your child needs 3 vaccines today. You can show them on the immunization schedule, and it protects against meningitis, HPV cancers, and pertussis. So one of the best practices, and this is documented in the literature, is through Denver Health. Denver Health has done an exceptional job. They're an integrated urban safety net health system, and they provide care to over 17,000 adolescents a year, many of whom are indigent. Their vaccination rates are outstanding. So for just initiating 1 HPV vaccine, 90% of their boys and girls have received 1, compared to our 65% currently. The Tdap and the Menactra are better than the national rates as well. And of interest is that the most compliant population happens to be females, Hispanics, greater than 200% below poverty level, and the non-English-speaking patients. So how do they achieve higher adolescent vaccination rates? First, they bundle it. If you're 11 or 12, boom, these are the 3 vaccinations your child is getting today. And then anytime the patient comes in for whether it's a sick visit, well visit, they're going to maximize those visit opportunities, and they're going to say, oh, your child missed a vaccination, or the child needs a vaccination, we're going to give that today. And they're certainly going to make strong recommendations, as we had just mentioned, about why the child needs the vaccine. And then standing orders, so if your child's 11 or 12, boom, the standing orders are right there. They're bundled together. And then school-based health centers has been very, very helpful as far as helping to implement the vaccines, and then using a vaccine registry. So of interest, though, too, is, there are different styles of discussing vaccinations and announcements versus conversations. And again, this is published because, again, we're trying to figure out what is the most effective way we can message to parents to convince them that your child needs to be vaccinated and vaccinated today. Announcements are brief statements that assume that the parents are ready to vaccinate. Conversations, though, are more of an engaging dialogue with open-ended discussion that you're going to do before you actually even recommend the vaccinations. When they compared the 2 types of presentations, actually the announcements were more effective in increasing vaccination rates. And I'm going to give you examples and you'll see, and this is probably very helpful. So an announcement would be, now that Sophia's 11, she's due for 3 vaccines. These will protect her from infections causing meningitis, HPV cancers, and pertussis, and we're going to give you those shots at the end of the visit. The conversation is yay long and basically discussing the vaccines. Even though she's due for them, we're going to go into a little bit in-depth discussion, and at the end, the question is, do you have any questions for me? So this could go on and on. This is a more long-winded presentation to get to the same point, but it leaves a lot of discussion to be had. And if you've ever been to a well visit, the well visits are usually 15 minutes max. Very difficult to engage in very long conversations with parents during that time. But parents do need reassurance, and we certainly don't want to discourage questions. When they're asking questions, we realize that they just don't have enough information, and our job is to provide that information. So we definitely want to make sure we're addressing their concerns. So we definitely want to make sure that we get to the heart of what their question is, though. And so here's some questions about that parents may ask you. So why does my child need the HPV vaccine? And the main reason is because it is cancer preventing, which is a very true statement. It prevents cancer. It's novel in that in that realm. Is my child really at risk for HPV? It's the most common. It's very, you hate to say sexually transmitted disease, but it is the most common sexually transmitted disease. It's widespread. Your child will probably be affected and not even know, and we can help prevent your child from being infected with this virus if we start vaccination as early as possible. And then concern about propensity to have early sex. There's absolutely no data to support that. Your child will actually engage in sex at a younger age because they've received the vaccine. Vaccine safety, certainly. So again, you hear a lot in the media, you may read a lot on blogs, but so many studies have been done, and you can point them in the direction of the CDC and show them that there's definitely active surveillance at all times with adverse events. Again, some of the side effects we talked about is not unique to HPV. It can happen to any child with any vaccine, and that there's no effect or detrimental effect on fertility, which may be a concern of some of the mothers for their females' children getting the vaccine. And we have over a decade of information to prove that there's absolutely no vaccine-related deaths or permanent neurological sequelae. And why do boys need the vaccine? Because boys can actually be infected, again, penis, anus, and oropharyngeal diseases, and genital warts, which again, cosmetically, very not appealing, but definitely psychologically can be very debilitating for our youngsters. And this is very common. I only want the vaccines our children need for school. And really important is that the American Cancer Society, American Academy of Pediatrics, American College of OBGYN, American Academy of Family Practice all recommend the HPV vaccine. So just because this is not a school-related, entry vaccination requirement does not mean that this vaccine is not essential for your child's health and well-being in the future. And then a question, would you get the HPV vaccine for your kids? I always volunteer this information. I don't wait for them to ask. I say, I have 3 kids, they're all immunized, and I started when they were 9. As soon as the vaccine came out, I jumped right on board because honestly, I'm all about primary prevention. We're trying to prevent disease before it actually occurs. And if the parent doesn't say yes today, honestly, it's okay. We want them to be vaccinated as quickly as possible and not waste time, but we realize that parents are going to want to study the information a little bit better. So, they're going to, you can ask again, clarify what their concerns are, acknowledge that, yes, maybe today they don't want the vaccine, but we leave the door open and say, but at any time you change your mind, and I may even give them a reminder phone call just to say, I know you've been thinking about it, any questions that you may want to ask me, and then obviously provide resources. It's all about education, educating our population so they understand the implications of not vaccinating our children. So if they decline today, it's not the end of the world. We're going to revisit this and hopefully end the conversation with at least one action you both agree. So maybe we'll see, Johnny or Susie in 6 months, and then we can discuss it again, or I'll call you and then we can discuss it in just a few weeks and see if you change your mind. Or I'll put the order in at any time. Please come by. You don't even need to see me. You just need to see the nurse for the vaccination. And the lovely part is that there's so many resources available for both our office workers as well as for parents, physicians. CDC does a lovely job. And how can we increase the number of kids that come through our clinic? Well, we have to make sure, and this is really important, that our office is in line, everyone in our office is in line with the mission. So every office worker, all the nurses and the MAs need to be educated on the importance of this vaccine. Because many times nurses will be asked, so do you think my child really needs to get this vaccine? And we want everyone to be on the same page and deliver the same message cohesively. And this is an excellent sheet that, again, discusses many of the questions that we reviewed. And this you can give to your office staff so they can actually review some of the answers and enlighten them on the benefits of HPV as well, though. So it's really important to have all of the staff saying the exact same thing, sharing the same message. And here's an example of, I may tell the mom, hey, your child definitely needs the 3 vaccines today. And then the MA and the nurse can also reinforce that message and say, oh, our practice is dedicated to cancer prevention. And, I'm sure your doctor will want to talk to you about your concerns, rather than saying, well, I'm not sure. I don't, your child might not need it. Or my child never received the vaccine and they're just fine. So we're hoping that everyone is on the same page. So this is a great cartoon. It's not that I don't trust you, Kevin. I just don't trust the women who've been with the men, who've been with the women, who've been with the men, who've been with the women you've been with. Very interesting. And this is actually a poster that the CDC can provide free of charge that you can hang on your wall. And it says, if there were a vaccine against cancer, would you get it for your kids? Pretty powerful, right? And there is a vaccine to prevent cancer. So we should be giving them to our kids. And hopefully we can convince our parents through our education that it is vital for their children to receive the vaccine. So again, some of the CDC available information sheets. And this is my husband, my 2 girls. My boy was in the other, but that is it. It's a pleasure.
Thank you, Dr. Lowe. At this
You're welcome.
time, we will unmute the line for questions. As a reminder, you can also type your question in the question box located on the webinar screen. So if you have a question, please feel free to ask at this time.
I have a question.
Sure. Okay.
Did we have someone on the line with a question?
Do you want to ask your question? We'll repeat it. So you can let them know that there's a question.
Oh, there is one question?
The vaccine is only good for 8 to 10 years. So do we recommend revaccination for how many 10-year intervals?
So currently, the studies, since it only came out in 2006, so up to now, they're saying at least 10 years duration, but they're ongoing studies. So it could be longer. They just haven't published that data. So there's still ongoing studies to demonstrate the actual duration, but 10 is the minimum at this point. And when we talk about the exposure to HPV, so again, it is sexually transmitted, but again, that age, which is the highest rate of HPV, is the 18 to 24, which is the same as the other sexually transmitted diseases. So once a person is a little stable in their relationships potentially, we should not see such an uptick in the HPV in the older populations though. One vaccination really should do it, but again, ongoing studies though. Dr. Cross? Would you like to comment, sir?
Yes, well, many of us that work in community health centers are in a unique position to make an important contribution to reducing HPV-related cancers. Our patient populations, for instance, at Excel, we have a lot of low English proficiency, or LEP Latinos. They have very little access to healthcare information. A lot of them, of course, get their required vaccinations for school, but don't realize about the HPV vaccine. So where a lot of them don't have the money to go to a pediatrician regularly, and they don't have a primary care physician. They seek medical attention when they're having emergency, usually going to the ER. So we're in a unique position in a dental clinic when they come in to educate them about the HPV vaccine. So we're going to be we're putting up posters both in English and Spanish, and also, asking patients about their vaccination records and checking vaccination records. I think we can do a lot of good with this. In addition, we're actually doing quite a bit of outreach, and now that I have a health educator, outreach worker, Hunter, he's on the line right now, but he's going out to the senior citizen centers and educating grandparents, and he will be including HPV vaccination along with nursing bottle caries and such, because when you educate a grandmother, you educate generations. Another thing with the Latinos, of course, they have 4 kids, so if you get one kid vaccinated, obviously the rest of them will follow suit, and so we can up that rate quite a bit. I guess another thing, of course, with working at a community health center, I mean, the medical clinic is just a few steps away, and you have a good relationship, hopefully, with the pediatricians and also with the medical director. And also, I guess there's ways of getting, we accept most insurance, and of course, some patients would not be able to afford it, and there's ways of getting a free vaccination too. So we all have access to that working in a community health center. So I think, it's our responsibility.
We only have one port in that Scanx, but you've tried the other ports on the laptop, correct? Okay, I am trying to get IT out there this afternoon. I put a ticket in last time I
charge for even uninsured patients. So if you get VFC vaccines, that is free, and you don't have to have any insurance for that, though. And so the immunization bus basically uses those same vaccines that Tina had mentioned. The immunization bus, those are all VFC vaccines. So you don't have to have any proof of insurance to get the vaccines free. So any vaccine recommended by the Advisory Committee on Immunization Practices, which is basically on the immunization schedule, is all available to uninsured or insured kids 18 years of age and younger. So that's exciting. So insurance is not even an issue at this point. Did you hear that, sir? Hello? I think, is he on mute? Because normally he would.
We're not on mute. Shannon, can you hear us?
Yes, I can hear you. Dr. Cross, please be sure to enter your audio pin so that we can hear you. It appears your line is muted.
I don't think he heard a thing I said. Dr. Cross?
Yeah, we can't hear you.
So I just wanted to, I'm not sure you heard, for the VFC programs, the vaccine for children, all children 18 years of age, even if they're uninsured, can receive the vaccine for free. Dr. Cross?
I think he's trying. Are you still trying to connect, Dr. Cross?
Yeah, he's still trying to connect. We can hear you, though.
Okay. I think what I want to do, if you don't mind, just for the people who are on the call, if you can just remember, there's a lot of evidence-based practice, of course, we know on the physician side, but what we're trying to do is really promote an increase of HPV vaccinations here in Louisiana, where we know there's a lower percentage than what we would like to see, but we are getting better at it. And so what we would like to do is, once again, right, this is about a collaborative approach to population health, specifically HPV vaccinations. And so just like Dr. Lowe was saying, If you are in the greater New Orleans area, there is a bus that offers these vaccinations for free to those who are kids, who are 18 and under. There are CDC posters that you can put, that's the second bullet point, in your office that many of them Dr. Lowe showed, which was great. And if you see the big picture over here on your right, those are posters that the Louisiana Cancer Prevention Control actually made for oral health providers in our state. And so if you would like some of those for your office, please let us know and we can get those to you. And then what's most important is, like Dr. Lowe, establish some office process. So the dentist, the dental hygienist, the dental assistant, the front office staff, on how you can help promote HPV vaccinations around that time frame. And then with that, I will tell you, if you are not in a community health center or a FQHC and you are in a private office, it will be helpful for you to get access to LINKS, which is the Louisiana web-based system. And as an oral health care provider, you can have access to read and view, not necessarily edit unless you're willing to take on providing the immunizations. But this is a way for you to verify before the individual comes into your dental office if they are up to date with immunizations and whether you should or you don't have to ask the question, are you up to date with your immunizations? So I'm hoping that's helpful to you.
Can you hear me now?
We
Yes,
can, Dr. Cross.
Okay, you couldn't hear me at all before?
Well, no, I heard, well, not after I started speaking, but did you hear about the VFC program? Did you hear me talk about that?
Yes.
Okay.
But you didn't hear anything that I said before?
No, we did. We did hear a lot of your support in terms of what,
Okay.
I think it was
Good.
Hunter going out into the senior centers and providing information to grandparents.
Perfect. Okay.
So is there
Yeah.
anything else you would like to say about this collaborative approach?
Yeah, well, in addition to, we've been we're going to be out with more health fairs, and we'll always promote HPV, at all the health fairs now. So that's we actually do quite a bit, and we're working with Tulane School Social Work with the Health Spot program as well too. So we'll be passing out information there. I think it's great to be able to help patients maybe 10, 20 years down the road. And I think patients will appreciate you more and more as they hear more about HPV cancer, on the media. It'll be more and more common, I would think, and they're going to really appreciate what we did for them.
So, Dr. Cross, you can always use myself or any of the primary care providers as a resource if you need us and have any additional questions about HPV vaccine. We'd be more than happy to help.
Thank you. Yeah.
Shannon, are there any other questions, or do you want me to follow back up with the continuing education credits?
Right now, there doesn't appear to be any questions on the webinar side, but we can give a few seconds while we give closing comments to see if there will be any questions. So we want to take a moment to just thank all of our speakers for conducting this presentation today. And Dr. Gonaldo, if you wanted to take a moment just to let the participants know how to receive their continuing dental education from today's webinar.
Perfect. So thank you all in attendance for the webinar session today. And so today was worth 2 hours of dental continuing education credit. Participation in the pre-survey and then a post-survey that you will receive shortly after this webinar, along with your attendance here at the webinar, will give you a 2-hour certificate. And so if you have any questions or you need any assistance, I believe I sent out an email to all participants, and so you have my email address, or you have Amanda Gumas's email address, who's the coordinator of our Interprofessional Education Office. And I think that's it.
And we'll also send out a copy of the slides to all attendees and post this recording to the OPCA website. And if there are no more questions, this concludes our webinar presentation for today. So thank you again for everyone participating, and have a great day.
Thank you.
Thank you.